So welcome everyone to National Conference of Tobacco Health. And today's session that's entitled CDC National Networks, Advancing Health Equity with the 10 Essential Public Health Services Framework. So during today's presentation, we're going to make this a little fun and interactive. So during today's presentation, if you learn something that's helpful or beneficial, or exciting, or thought-provoking, or heartwarming, or maybe just something that really spurs your thoughts, please feel free to use social media. Go to Twitter using the hashtag NCTOH 2022. Maybe some of your colleagues who are following us on Twitter may be able to learn just a few things from today's session. So we'll begin. So the good news is that as part of this session, we wanted to ensure that we've highlighted the 10 essential public health services framework, as well as the Healthy People 2030 objectives. And those are central tenets that are utilized by 8 of the national networks. So you'll hear from about 6 of our national networks during today's presentation. And these are national networks that are established to address both tobacco and cancer-related disparities that impact some of the nation's most vulnerable populations by race and ethnicity, by region as well, and by factors such as low socioeconomic status factors. You'll hear a few examples of strategic partnerships, evidence-based interventions, as well as best and promising practice that are all grounded in health equity. I don't have any disclosures to reveal. I'll wait for IT, and I think it's working, but we'll keep talking. We don't have any disclosures. We wanted to make sure that everyone has a clear understanding of what we mean by tobacco-related health disparities. Let's see. Can you get another clicker, please? So the National Cancer Institute helped to publish what's called the monogram that's entitled Social Ecological Approach to Addressing Tobacco-Related Disparities. And so these disparities are so important as you are working with partners, new and existing partners, as well as just potential decision makers who may be new to the concept of disparities or just tobacco-related disparities. And these disparities are defined as differences in patterns, prevention and treatment of tobacco use, differences in tobacco risk, incidence, morbidity, mortality, and the burden of tobacco-related illnesses that exist among specific populations in the United States, as well as significant and or persistent differences in capacity and infrastructure, access to resources, and environmental smoke exposure. And this is important as we're thinking about reducing tobacco-related disparities, for instance, in food deserts or in areas that have limited pharmacies, limited numbers of pharmacies, or as well as some low-income work sites as well. These differences also involve, more specifically, differences in access to healthcare, access to quality healthcare, especially among populations who use tobacco products. These differences also include socioeconomic indicators that impact healthcare, psychosocial and environmental resources. And then lastly, these differences also include differences along the tobacco use continuum. And this is important as we're thinking about exposure to tobacco, tobacco use initiation, and that's why you're going to hear from Michael when he talks about menthol. But this is so important as you're thinking about young populations that use e-cigarettes as well. These differences also include current use, and that includes tobacco users who are maybe considered poly users or dual tobacco users. These differences also include the number of cigarettes smoked, but this also includes smokeless tobacco products as well. Differences in quitting rates or relapse rates, as well as differences in health consequences that are associated with tobacco use. So that may include significant differences in lung cancer, morbidity, and mortality as well. And we'll just continue to go through, I'll continue to talk through some of the information, and then you'll see them on the slides as well lately. In the next few minutes. And so the 10 essential public health services framework was originally developed in 1994. How many people knew that? 1, 2. Okay, good. So we have a good audience. Good. So then everybody will know now from this point on. All right. So it was developed in 1994. And while I was so excited when this most revised model was developed, because this is the first time that it's centered around equity. And this is wonderful because this way it provides additional opportunities to reach even more populations in all communities nationwide across the lifespan. And that's why it's just wonderful. While at the same time addressing persistent disparities related to tobacco and cancer. And so as part of this public health service model, there are 3 domains. You have the assessment domain, one of my favorites. It focuses on data and then utilizing that data to address root causes that are associated with health disparities, and also to utilize that data to work with multi-sector partners as you're educating them on why addressing disparities is so important. And that's followed by your policy domain. And you'll hear a bit more from our panelists on the policy domain aspect as well, policy development domain. And then the assurance domain, and that was comprised of some of our last presentations. And so as a part of our model, recognizing that there are multiple levels of influence that impact tobacco-related disparities, you'll hear a little bit more about some collaborative strategies, some lessons learned from our panelists, and just some other ways that our national networks expand reach to reach even more vulnerable populations across the nation, as well as the importance of addressing the interconnected disparities. You'll feel a bit more about that too, as it relates to tobacco prevention, tobacco cessation, policy adoption, community clinical linkages, health systems, and behavioral health services that affect our nation's populations. And so as part of one of the domains that I referenced earlier, the policy development domain, we're so excited that as CDC national partners, alongside additional national partners, we developed, using data from the assessment domain, we utilized data to develop an educational campaign. And so that educational campaign, thank you so much. Let's see, do this. Oh, okay. So I want to show everybody the model first so that you have an idea of what it looks like. It's an essential services framework. So you hear from some of our national network members here, and you'll get to keep the slide. So let's see, here we go. So now we're on the policy development domain. Okay, there we go. And so if I mentioned your organization as part of the CDC national networks, please raise your hand so that everyone in the audience will know who you are as well. So as part of the policy development domain, it includes one aspect that's entitled Communicate Effectively to inform and educate people about health, factors that influence health, and then how to improve it. And so the name of this educational campaign that was launched in January of 2022 was entitled National Conversation on Preventing Addiction from Menthol and Other Flavored Tobacco Products in All Communities. See the tag, the 10 Essential Public Health Services Framework in all communities and a path forward. And some of those examples of some of our CDC national partners included, of course, Self-Made Health Network. So we use data and theory and research to develop the framework for this campaign. Public Health Law Center, are you here? No, they were excited about this presentation. So maybe I'll come later. Center for Black Health and Equity. Okay, North American Quitline Consortium. National Alliance for Hispanic Health. I know Marcella, they have another presentation. We have one the same day. Also, Campaign for Tobacco-Free Kids. National LGBT Cancer Network. There we go. Truth Initiative. Yay, there we go. Okay. Counter Tools. Okay, good. So we'll keep going, and I want to make sure everybody gets time. All right. And then additional CDC partners included Geographic Health Equity Alliance, the American Cancer Society Cancer Action Network, American Lung Association. Oh, there we go. Okay, sorry, I get excited. National Behavioral Health Networks for Tobacco and Cancer Control, American Heart Association. Oh, good. Okay, along with some of our CDC national partners and network members, including our COPD Foundation partners, and also the University of Nebraska Center for Reducing Disparities. And what was so wonderful is that in addition to our CDC national partners, this educational campaign was supported by the CDC's Office of Smoking and Health and the CDC's Division of Cancer Prevention and Control. And then this is just a snapshot of some of those results. We're asked to provide additional information as part of our CDC success stories, but at least it gives you a preview of some of those results. So these are 1-hour Twitter chats. How many people are familiar with Twitter chats? 1, 2, okay. So it's kind of like a 1-hour dialogue that focuses on a particular topic, and you can invite the entire world to engage in these Twitter chats. So we held 2 Twitter chats. One was held January the 12th, and it generated 31,954 impressions. And impressions are the number of times that this tweet was seen in 1 hour. And then the second Twitter chat, yeah, isn't that nice? Because I was like, oh, we stayed the whole day. We'll probably be just rolling along as, okay. So the second Twitter chat was held on January the 26th, and it generated 16,446 impressions. And so without further ado, I want to make sure we introduce the rest of our panelists. So we're going to have our first presenter from the National Native Network. Hannah, you ready? Sounds like that you are.
So, bonjour everybody. My name is Hannah Bartle. Before I get started, I really want to acknowledge the land that we're on. New Orleans land is historically Choctaw Indian land, so I just really wanted to acknowledge that before I got started. Today I'm going to talk about strengthening and support communities and how we can mobilize them and what that looks like really in tribal communities. So disclosures, I have no financial disclosures or conflicts of interest presented in this material. So American Indian and Alaska Native communities. The American Indian and Alaska Native communities have this innate strength and resilience that's deeply rooted within their tribal, cultural, and traditional ways of life. However, we know that a lot of cultural traditions have been severely disrupted by colonialism, loss of land, policies such as removal, relocation, termination that results in historical trauma that really affects our chronic disease rates and underlying risk factors such as obesity and commercial tobacco use. But we also know that Indigenous folks are super resilient, and we integrate our cultural beliefs within our practices into public health policy, delivery care systems. And we're learning that culture is really prevention. So we're really integrating our culture within our way of life and how we can really elevate the health of our folks in our tribal communities. So American Indian Alaska Natives, I really want to look at strength and support and what that looks like within our communities. So when we're looking for that, we look for partners who have this deep stake in creating healthy communities, healthy relationships, and they really want to contribute to the positive impact and positive, healthy lifestyle choices that our folks really want to make. When we're looking for partners, we really want to make sure that their program is really service focused, really customized to our tribal communities, because each tribal community is different. My tribal community back in Michigan is going to look different than somebody's in Montana or somebody in the Southwest or somebody even on the East Coast. So we really want to make sure that our partners really have a stake within how our community is, runs and whatnot. We really want to make sure that our tribal leadership and community really has a say within our programs and how we want to run our systems, because we know that, our tribal leadership and our tribal executive system is really what runs our community. And we really want to make sure that we bring those conversations as well, as long as our tribal elders, because we know that our elders really have a stake in what our community looks like and how they want our community to be for our future generations. So we really want to make sure that we're bringing the entire community in these decisions and making sure that everybody sort of has a say in how their home community is run. And we really want to be data oriented. And when I say data oriented, I really want to make sure that folks know about, the data inaccuracies and the data history between Indigenous folks and the United States government. And when we do collect data, we really want to make sure that our Indigenous communities are at the center and at the focus of this data, and that they really get to keep our data, because our data looks different in many ways. We have, our qualitative data and our quantitative data, and sometimes that doesn't really always look like the data that we know today. It can be storytelling, it can be pictures, it can be, oral histories and oral traditions. So we really want to make sure that we're looking at all kinds of data when we collect data for our Indigenous communities. And partnerships, what does that look like in tribal communities? So as partnerships are grown and built and improved within Indian country, we are aiming to address the social determinants of health within our communities as well. And we understand that these are fundamental to the success of our programs within tribal communities. And it really sustains our work, and it really makes sure that our programs are, being run year after year, and we're just improving on all of our data. So we really want to improve overall tribal wellness, and like I said, that really is looking at all of the aspects of our tribal community. It's looking at our tribal clinic. It's looking at our, it's looking at our education system. It's looking at all of these systems coming into one and making sure that we're all in agreement to, really elevate the healthy lifestyles of our community. And we're really looking at the infrastructure for our epidemiology centers, our tribal epicenters, and making sure that they're running at the highest capacity that we can. We saw with COVID that they really did a really great job, because we saw that COVID, really hit Indian country really hard, but we were some of the highest rates of vaccination throughout the country. So we really want to thank those folks who are first responders in our epicenters. So to make us the highest vaccinated folks within the country, and really want to we really want to integrate traditional and cultural lifestyles within our health systems to improve our health and wellness, not really looking at Western medicine all the time, and making sure that we're bringing in our traditional healers, we're bringing in our traditional medicines to really bring those two together and really to just help elevate people's, mental, physical well-being. So knowledge and strategic planning, what does that look like in our tribal communities? Knowledge, we really want to build our data or build our public health data infrastructure that fits each tribal community. The way we collect data in Michigan is going to be, where I'm from, is going to be different than the way they're collecting data in Utah, or how they're collecting data in California. So we really want to make sure that folks understand that data is going to look different, geographically, and it's even going to look different with the different tribes that are in each state. A tribe in the Upper Peninsula of Michigan is going to look different than the tribe in the lower part of Michigan. So we really want to understand that and customize that to each tribal community. We really want to improve the methods of collecting our data. And like I stated before, data really looks different within Indian country, and really want to make sure that folks are looking at all of the ways to collect data. Like I had said, storytelling, art, sometimes it can be, dancing or singing. So really making sure that you're looking at all aspects of data and applying those findings to have effective action, and not just taking that data and sort of, leaving that tribal community, and making sure that tribal community really has access to that data and really has access so they can move their community forward. And strategic planning, really create an action plan through all of the things that you collect through tribal communities, and making sure that your tribal community has a voice within that planning, because you don't want to create a plan that's going to work for another racial or ethnic group, for Native Americans. You really want to make sure that this is really community focused and really focused on those people. And then ensure that those communities are equipped with that knowledge to keep that program going. You don't want to create something and then it fizzle out within a year or two. You really want to make sure that community is equipped to have that knowledge. They're equipped with the workers to do it, and they're equipped to keep this community going, to continue on and giving the next generation the knowledge, because we really focus on the generation that's coming afterwards. Right now I'm doing this work as a young person, but I'm looking, a couple generations before me to make sure that my grandkids' kids have, a good home community. So we're really looking forward to making sure that my community and all tribal communities are equipped to keep this knowledge. So miigwech, or it means thank you in my language. So I really want to say miigwech for letting me talk about tribal communities. And if you have any questions, we'll have time for that later. But all of my information is on the bottom, and I encourage you to come see us in the exhibit hall. We have really nice bags and pins. So take one home.
set my timer. All right, so good morning, everyone. My name is Michael Scott from the Center for Black Health and Equity, and our organization, too, is going to talk about how we utilize strengthening, supporting, and mobilizing communities and strategic partnerships to improve health. Okay, here we go. So, as you know, we're 8 networks that work specifically, as we said, with priority populations that have been disproportionately impacted by tobacco use and as a result suffer worse consequences from tobacco use, from cancer. Our organization works specifically with the African American community in the United States. And we do this by providing trained TA, but also by building capacity, community capacity, developing community infrastructure, and advocating for equity-based policies, like the FDA rule. So, I mean, we've been working on that for years. It was a policy, a flavor policy, but it wasn't equitable. So equity-based policies is another key initiative that we're focusing on. And how we do it, part of how we do it is through a 5-part training series that we've created. And through this training series, we work with communities, coalitions, lead agencies to build their capacities, build their infrastructure, to advocate for change within their communities. So we're not doing the advocating, the community is doing the advocating. And we know the community is the asset. There's assets within the community, but the community itself is the asset. So the goals and objectives of this 5-part series that we put together is to increase the capacity of the trained coalitions. And when I say trained coalitions, we're training them. So once they're trained, they're able to then promote the adoption of evidence-based strategies towards tobacco-related policy, systems, and environmental change. The objective of these trainings is for us to build that capacity by providing skills trainings to achieve that PSE change, whether it's smoke-free air, whether it's menthol policy things. And the good thing, a positive thing, an extra is that even after the training and they've done the work, say, to smoke-free air, these trainings that they've received are then applicable to any other social or racial or health-related issue that's impacting the community that this coalition then wants to take on. And our strategies around that, and this is going to be high level, so I'm not going to mention every single step of the way. This is kind of high level, and if folks are more interested in a deeper dive, we definitely have conversations later on. But a few of the trainings that are involved in this 5-part series are going to be community or coalition development. So it could be a fresh, brand new coalition that needs to start from ground zero. We'll take them there. It could be a coalition that already exists. So we're not necessarily training or developing the coalition, but maybe massaging it, building their capacity, their infrastructure. And a few things that you're going to hear me say, you're probably going to hear repeated. Like a few of the things Hannah mentioned are things that we include. And that's just how important it is when you're working with communities. So data collection, especially local data. If you're working in a African-American community in Kansas, it's going to be a little bit, that may be a little different than an African-American community in, say, New York City. So data collection is important. Education campaign development. All right, we want a policy change. We need the community to back us up. So we've got to train the community on why that policy is important, and then how to then advertise, how to communicate that policy to the broader community. Community mobilization, same thing. You got to mobilize the community to get behind the effort. Policy development, identifying champions. A policy development piece is key because, as we see, I've been working in tobacco. if you don't have that policy language tight, there's going to be loopholes. There's going to be opportunities for big tobacco or whatever opposition to come in, maneuver their way, block it, change it, make it take years to be effective. So policy language is important, and we help develop that. Identifying a champion, someone in the community that's trusted, someone in the community that folks listen to. Action plan development. So the initial idea that a coalition has is awesome, but we gotta have a plan, an action plan, a detailed action plan. So we help facilitate what that process is, what it looks like, the evaluation plan, and then the enforcement plan, depending on what the policy or system change is. Now, of course, we can't enforce it, but we can help with the language of the enforcement. For example, with the FDA rule, there's got to be cessation tied into that somewhere. So making sure that when they write that enforcement plan to present to whomever they may be presenting it to, that enforcement question is answered, or they're prepared to answer it. So the theoretical approach behind this is based on Dr. Bob Robbins's community development model. And I think a lot of folks in this room, a lot of folks on this panel are utilizing this model, maybe not even realizing it, but it takes 4 concepts into thought and really delves into that. The history, the culture, the context, the geography, and why that's important. The history of it is important because the history then captures the important phenomenon within that specific community that will impact how this community works together, how this community is received by the decision makers, by other parts of the community, because 9 times out of 10, with our populations, we're going to be the minority in the community, and our voices may not be heard because of historical context. Culture includes values, faiths, beliefs, and norms that are not always the same. Like Hannah mentioned, it's not a monolith. You know, there's different tribes that have different cultures and norms. African Americans, the same things. It's not a monolith. None of the priority populations are a monolith. And the geography and the context, geography is where we're located. How's that impact? How's the environment impacting this? Is there a lot of waste? Is there a lot of pollution? And I know I'm running out of time, so let me get that. So the roadmap. So after the training, there's 5 specific trainings, 1 through 5. The roadmap is the end piece. Everything goes into the roadmap, and this roadmap is what the coalitions, the lead agencies will present to the decision makers. The decision makers are going to have lots of questions. With this roadmap, the coalitions, lead agencies are prepared to answer those questions visually. It's a virtual roadmap. And this is a blank one, but that gets filled in with links to answer where the data came from. What are the projected positive influences or outcomes? What are the talking points to the negative outcomes or the negative pieces that big tobacco, of course, is going to come with if tobacco is what you're working on? So we want to be able for them to be able to share everything. That's why we provide the roadmap. And again, the roadmap starts from day 1. Everything that they work towards is included in that roadmap. So at the end, they can present, this is why, this is how, and this is when and where and why. And this is how we're going to do it. And again, that was high level. So this training, again, it's a 5-series training that could take up to a year, depending on the coalition's readiness. And readiness is one of the things that takes place way in the beginning. So again, I couldn't go into all 5 parts of the series. But again, we have another session or another training that can really give you all a better, deeper understanding if that type of training is something that folks are interested in. So, go to our website, tap me on the shoulder afterwards, and we can give you a better, deeper explanation of how this series works, and even give you some examples of how we've used it and what those outcomes have been.
Hello, everyone. My name is Michelle Ju, and I am the program coordinator and Aspire. My name is Michelle Ju, and I'm the program coordinator of the Aspire program at Appeal, which stands for the Asian Pacific Partners for Empowerment, Advocacy, and Leadership. I wanted to thank everyone for joining this subplenary, Calhoun, and all of the other networks, and also all of you who have been doing this work that we do. And I'll be discussing how to mobilize community partnerships into action, essential public health service number 4 in the policy development area of CDC's model for health equity. I have no relevant financial relationships or conflicts of interest to disclose. Before we begin, I'd like to provide some quick information about our organization. Appeal is a national nonprofit working to advance health equity and social justice, to eliminate tobacco and cancer health-related disparities in primarily Asian American, Native Hawaiian, and Pacific Islander communities. Founded in '94, since then it's established itself as an important national network providing key technical assistance and resources on health justice. Appeal implements the Aspire network, whose goals are uplifting health equity for all populations. And we're one of the 8 CDC national networks jointly funded by CDC's Office on Smoking and Health and Division of Cancer Prevention and Control. Find us on our socials at Appeal for Health. So for this, I would really now like to provide a quick framework for health equity from CDC. Health equity is defined as the state in which everyone has a fair and just opportunity to attain their highest level of health. Achieving this requires focus and ongoing societal efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to health and healthcare, and eliminate preventable health disparities. So how does Appeal fit into the health equity model? We do this by helping with the development of policy and programming through a social and community context that uplifts the community infrastructure and mobilizes communities and strategic partnerships. And we really work to advance our partners through health equity, institutional and systems change, and building community power to change social norms. And we do this with an asset-based approach to capacity building and a primary focus on leadership development. So over on the left-hand side, we see the health equity paving the roads to that. And then on the right-hand side, we have the social determinants of health. So essential public health service number 4 is concerned with strengthening, supporting, and mobilizing communities and partnerships to improve health. Constituency development, identification of systems, partners, and stakeholders, and coalition development, and then formal and informal partnerships to promote health improvement. And what does that mean for us? That really means looking at building coalitions and partnerships and strategic alliances to draw upon the full range of potential human and material resources to improve community health. And convening and facilitating partnerships and strategic alliances so that among our groups and associations, and that includes those not typically considered to be health related as well. So this is an undertaking defined by health improvement projects, including preventative, screening, rehab, and support programs. So I have this list again. So it's convening and facilitating multi-sector partnerships, fostering and building genuine strength-based relationships, authentically engaging with community members, and learning from and supporting existing community partnerships. The next 2 slides kind of take a look at state public health performance standards, which are found on the CDC website. And it looks at the interconnection between state and local public health issues that we have an overlap. So what does this really mean, and who are we talking about? This actually is 2 areas that we can look at. So we can look at our stakeholders and constituencies for coalition and capacity building. And that could be anything from local and governmental health departments and agencies, transportation, faith-based institutions, or any number of the things listed in this slide. And so I'll actually start with some cases. For community level partnerships, we have one of our local partners is Center for Asian Community Services. It's known as CPACS. They wanted to be a voice for the diverse community. And what did that mean? So they, along the Beaufort Highway in Doraville, Georgia, they had noticed a lot of issues with the built environment, a lot of litter, including things like cigarette butts, alcohol, lots of drug needles, things like that. So they really thought, we could really tackle the tobacco issue. And how do we do that? We do that with a youth engagement. So they did a needs assessment. They have their own youth task force. And then they really started with looking at, how to reach out to the community. And they started, having never done this before, reached out to their city council members and were able to get their youth to attend a lot of the council meetings per month. And then they actually, through this, they made more introductions. They were able to make connections to larger nonprofits like the American Heart Association and Smoke Free Atlanta. And then they identify champions from within the youth, within the community itself, so including like retailers and other local businesses, and also among city council and the coalitions that they were really building. And so this is really how they got the community engaged. They started coalition building, and then they did the stakeholders and constituencies. And what did that actually result in? So CPACS was instrumental in getting an ordinance passed in Doraville, Georgia in November 2020. And so this ordinance prohibits smoking on all city-owned properties and in all city-owned structures and bans any kind of smoking within 20 feet of the entrance to most public places and residential common areas. This is really the hard work of the youth and the community itself. So that's really, how we start building at the community level. So like I said, how did CPACS help? They passed the ordinance in Doraville, Georgia in November 2020. And then they were actually able to expand the smoke-free laws to Gwinnett County, Georgia. That was effective as of last week, June 23rd, 2022. So, and furthermore, they're doing ethnographic study of the effects. So they really are going out into the community and training their youth to really, take a look at what works, what doesn't, and how does the community really feel about these tobacco use and, what they need to, continue to do. So continued education, advocacy, and policy support. The lessons learned from here is making connections, making the partnerships and building those out is really key. Seeking out those who really care about the issues, and then engaging the community to be authentic and being authentic. So here are some of our other community partners, Huey Malama in Hawaii and Las Vegas Hawaiian Civic Center. My next example is the multi-sector level partnership. It's a Southern Nevada Health District, and they really wanted to take a look at getting the research and numbers to make a difference. So this was actually a project that Malcolm Alo, so raise your hand, Malcolm, I know you're in the room. He's a tobacco control program coordinator at a Southern Nevada Health District. And after doing a general statewide adult tobacco survey, it really showed a need. He really wanted to work towards getting the grant funding to collect data on NHPIs and LGBTQIAs. And so Appeal really helps with facilitating the connections with partners, so local partners such as Las Vegas Hawaiian Civic Club. And then they really worked with Nevada State Policy and Nevada Institute for Children Research and Policy to collect disaggregated data on NH and PIs and LGBTQIA participants living in Southern Nevada. So this was looking at focus groups, tent surveys, and funding for research and community priorities. And what they did was they used this data collection to really, push for policy and programming change, including so there are new things that they're looking at right now are tobacco cessation protocols and lines. And as before, it actually resulted in this report. So it's pictured above. It's the tobacco report that looks at those subpopulations in 2021. And so, with this, they were able to actually have real statistics to inform and drive change and really acknowledge community readiness levels and continue to assess them. So what are our lessons learned? Those are to respect wisdom of the community and be humble. Open in order to create a safe space for compassion, inclusivity, and intersectionality. And then really looking at cultural advocates being intentional and convening, facilitating multi-sectoral partnerships to foster and build strength-based relationships. And this really takes work to build trust and strengthen these relationships. So I'll go really quickly through the next few slides through some of the information. Our next one is actually the LAMP Institute. This one actually is a leadership thing. Institute, and it's a year-long leadership institute that actually looks at cross-cultural collaboration. And you really need to train your future leaders to do what you need to do. We do a lot of work with this, our national networks, so that's also a lot of collaborative work that we do. And this is from one of the most recent webinars we had. And then the most important thing is building coalitions. It's important for policy systems and environmental change to actually have a really successful coalition development. We have an evaluations thing, so we look at social network analysis. We want to actually improve how we do well on these. So this is looking at all the connections through our partners and how we can really improve, and also the technical assistance training and reach that we do. And our evaluator, Linda Boss, was really great with that. And then last thing, promising practices that we're all doing. We're actually building resources and toolkits on our websites for you guys to use. And the final thing is youth sustainability. So youth leadership and engagement is really the future. As I showed you guys before from CPACs, that was really instrumental in getting the changes that we needed to do. So here's some of the examples from our youth. We have CPAC's Youth Commissioner on Health in Dorval, and we also have the Youth Tobacco Champions who created these wonderful infographics to distribute among themselves. All right, thank you.
Hi, good afternoon, everyone. Hopefully everyone can hear me. Great. Hey, hi everyone. My name is Ikra Haji. I'm a manager with the Geographic Health Equity Alliance, and today I'll be discussing our work related to Essential Service Area number 5 in the policy development domain. I have no disclosures to report. So the Geographic Health Equity Alliance, or GEO for short, is housed at CADCA, Community Anti-Drug Coalitions of America in Alexandria, Virginia. And so our national network is focused on reducing health disparities related to place. So in tobacco control, this means that we focus on supporting states that are part of the Southeast, the Midwest, Tobacco Nation, and rural and frontier communities. I want to take a quick second to introduce my amazing team, some of whom are here in the audience today. We have Andrew Romero, who is our director, who will actually be joining us for Q&A. Kellen Shelter, who is a fellow manager. We have Carolina Duth, who manages our evaluation and research activities. And we also have our wonderful intern, Alex Prizanzano, here today as well. So I'm sure you all are already aware, but research has shown where we live, work, and play can have a large impact on our health. And we believe that one of the main drivers of these differences in health from place to place are differences in health policies. So a main focus of GEA is looking at differences in smoke-free policies, and we work closely with state programs to support places that don't have comprehensive smoke-free laws. So as I mentioned earlier, we'll be discussing our work related to service area number 5, which is to create, champion, and implement policies, plans, and laws that impact health. So I'm going to highlight today one of our main flagship programs, our annual Geographic Surveillance Learning Collaborative. We've had 2 iterations of this collaborative so far, with the last cohort ending this past May. So this is a 12-month collaborative where state teams work on a project designed to build competence in the areas of legal mapping and communicating about geographic health disparities. To help support this collaborative, we partnered with Countertools and Temple University Center for Public Health Law Research. And our collaborative is grounded in the teachings of the Policy Surveillance Program, which is created by Temple University Center for Public Health Law Research. The center is a leader in legal epidemiology and the policy surveillance field. And the Learning Collaborative was inspired by a set of trainings Temple offers to state health departments. And so these trainings take health departments through a series of rigorous methods designed to create high quality and unbiased legal data. And before I go into how we tailored this concept for tobacco control, I wanted to give a few background definitions. I promise there won't be any complicated legalese. So first, within public health law, legal mapping is a process for capturing important features of laws and policies and for identifying how they vary across jurisdictions or institutions over time. So this is a critical concept for us at GIA because, as I mentioned earlier, we are very interested in looking at the differences in health policies from place to place. And the focus of our learning collaborative is policy surveillance, which is a form of legal mapping. So policy surveillance is the systematic collection, analysis, and dissemination of laws and policies across jurisdictions or institutions and over time. So what is unique about the policy surveillance process is that it uses a rigorous scientific process to create legal data for evaluation and research. So what you see here is the iterative policy surveillance process. And because there's an emphasis of this process in generating high quality and unbiased data, there are a lot of redundant processes. So in other words, many of the steps done are done by two people separately and then reconciled. And so this contributes to the overall quality control you see here in the center. So in our learning collaborative, we use policy surveillance methods to analyze tobacco control related laws and policies. So this is a big picture view of what we hope to achieve through our collaborative. So first, by teaching NTCP staff policy surveillance skills, we hope to improve the quality of policy databases housed within tobacco programs. And with a high quality data set, we can ensure that when we're measuring policy progress for the different NTCPs, that we're actually measuring what we think we're measuring. So we'll then be able to better understand whether our work is having an impact, and the states will better be able to understand any areas that they might need to focus on. We also think that by bringing some consistency to the policy surveillance process, that the states might be able to learn from one another and have more informed conversations about their policies and how they align with best practices. Also, having a high quality and unbiased policy data set would help us better understand where the different needs are in the different states. And lastly, our biggest hope and dream here is that while we've identified policy surveillance activities are something that all the different tobacco control programs do, we've learned that the programs don't use similar methods across the states or even internally across program areas. So as public health moves further into policy systems and environmental change, many areas of public health are going to be dabbling in policy surveillance. And so the methods and practices of the field of policy surveillance are going to be even more critical for public health practice. And we believe that OSH can really lead the way in adopting policy surveillance competencies within its programs. So now that I've gone over the long-term goals of the collaborative, I'll share its structure. In this year's cohort, we have 3 participating state teams from Indiana, Kansas, and Florida. And we originally also had Texas and West Virginia join the cohort, but due to staffing challenges brought by COVID, we had to take a step back. And so each state team consists of a minimum of 3 public health professionals from their national tobacco, comprehensive cancer control, and EPI programs. State teams were allowed to choose what type of policy they were going to assess during the collaborative. And so after discussions with the states, talking through their priorities and their work, they all chose to work on comprehensive K-12 tobacco-free school policies. So 2 of the states had no formal database for their K-12 school policies, and 1 of the states had a database but wanted to significantly improve the quality of that database. So over the course of 12 months, we took the state teams through Temple's policy surveillance process. And we had a kickoff meeting, we had 3 trainings, a working session, and the state teams worked on completing redundant coding before our wrap-up meeting in May. And after each of the training, states were asked to complete specific assignments. And so these assignments came together to produce 3 main products, which states can use as part of their policy surveillance process moving forward. And these products were a research protocol, a code book, and a data set. So the research protocol outlines the entire methodology and process of the project. It ensures that the project is replicable and transparent. And having a research protocol also helps when you have team members that leave the project and you need someone to come pick up where they left off. Next is the code book, which is a complete list of questions that will be coded in a legal data set. So the teams in the collaborative jointly developed one K through 12 school tobacco policy code book. And to prepare for this, each state did some background research on the policy issue and analyzed policies from different school districts. And from this analysis, they developed a set of questions to try to capture all of the important policy variables. And again, this code book is something that the states can keep with them and use in the future. Last is the online data set. So for our collaborative, we used Monocle, which is a software application developed by Temple's Center for Public Health Law Research. And it is designed to identify, code, and analyze legal policies, and then visualize, share, and update legal research findings. And we've learned that state tobacco programs use all sorts of different softwares to code and track policies, ranging from Excel to Tableau. And so one of the cool things about Monocle, even though it has its perks, is that it's designed for legal citations, meaning that all the legal data you choose will link back to the corresponding parts in the actual policies. So in May, we completed coding with the state teams. And now each state team has a foundational set of policies they can build upon. They have a research protocol, a code book, and a better understanding of the policy surveillance process. And we think this pilot program was a success, and we want to thank the state teams for participating. We learned a lot along the way and received some great feedback from the states, which we'll incorporate in the next iteration of the collaborative. So stay tuned for more information on the next collaborative, which will most likely rename Policy Surveillance Learning Collaborative. We expect it to begin in the coming year, and we encourage all state tobacco, cancer, and epi programs to apply. I wanted to give a very special thanks to our wonderful partners and teams who supported us on this collaborative. You can learn more about our work on our website, geohealthequity.org, or feel free to email me directly. And thank you for your time.
All right. Welcome, everyone. So I'm Timana Patel, Director of Practice Improvement at the National Council for Mental Wellbeing, and I'm going to talk a little bit about what we do through the National Behavioral Health Network for Tobacco and Cancer Control related to Essential Public Health Service number 7, enabling equitable access to tobacco control. I have no financial disclosures or conflicts of interest. Okay, so a little bit about the National Behavioral Health Network. Our administrative home is at the National Council for Mental Wellbeing, and what we do really aligns with the National Council's mission, and that is ensuring equitable access and quality of care. We are, again, one of 8 civilian networks funded through the CDC to address tobacco and cancer-related disparities for individuals with mental health and substance use challenges. We work with a wide array of stakeholders, including public health, behavioral health, primary care, as well as education. We've also, in the work that we do, have engaged partners from the Behavioral Health and Wellness Program, as well as the Smoking Cessation Leadership Center and the Michigan Public Health Institute. And so what we do collectively through MBHN for short, is providing access to tools, resources, toolkits, trainings, masterclass workshops, presentations, state strategy summits, and virtual communities. All right. So I want to start in grounding us in this, and I know this is not news to you all, but for behavioral health, I think it's really important to understand that 1 in 4 individuals in the United States experience some mental health or substance use challenge, and they consume up to 40% of all commercial cigarettes. And so we like to frame what MBHN does, how we do it, and why we do it the way that we do, really around equity and disparities, grounding in those root causes for and determinants of health, so we aren't left speculating
what the tobacco determinants are for individuals with mental health and substance use challenges. So we know that our health and our health outcomes are really driven by not just our own behaviors, which in behavioral health we often see traditional addiction discourse and programming really tailored towards our own health risk behaviors. But there are other factors obviously to consider. Now this is getting a little trigger happy. Hold on. Okay. That we have to consider, right? That are outside of our locus of control. That's the environment, community, societal factors, access, right? So if we don't consider these other factors, we're left somewhat lacking in our approach to really address the disparity. And so we have to consider from a systems perspective, what is it that puts people at risk? And how do we design and develop, implement interventions in response to those drivers? So our work with state tobacco control, as well as behavioral health providers and facilities, are really grounded in these evidence-based practices, right? Tobacco use screening, cessation counseling, offering nicotine replacement therapy, other cessation medications, as well as smoke-free facilities, right? And here what you can see, I don't know how big that font is, but here you can see how we're currently doing. And this is from 2020, and where mental health treatment facilities as well as substance use treatment facilities are in applying or not applying these evidence-based practices to our behavioral health population. And so NBHN has really been supporting state tobacco control programs and providers with ensuring equitable access through some of our offerings, such as our state strategy summits in partnership with the Smoking Cessation Leadership Center, as well as our communities of practice. Our communities of practice is a 6-month-long practice change initiative, really tailored to reduce these tobacco and cancer-related disparities among individuals with behavioral health conditions by leveraging these evidence-based practices. We lean into our expert faculty and their knowledge that they bring to the field through one-on-one coaching during the 6 months, as well as facilitating that peer learning exchange. I think it's also important to note that when teams come to us and engage in the community of practice, everybody's at a different place in their journey where they might be starting, and that's okay. It's actually what helps facilitate that peer-to-peer sharing even more. So in the following slides, I'm going to give you a couple examples of how what we've done through our offerings, how other states have taken advantage of it. And so here you see components of ensuring an effective system that enables equitable access to services and care, really to ensure that healthy living and mental well-being, right? All right. So in 2008, and I don't know if we have anyone here from New York, but in 2008, they were the first state to require all state-funded and state-certified substance use treatment organizations from prohibiting smoking on any grounds, and that included their outdoor areas. 2 years later, New York hosted a state leadership academy or state strategy summit, and that is led by our partners at the Smoking Cessation Leadership Center, and we co-host that with them. And through the state strategy summits, what happens is it's a statewide summit that really brings together key stakeholders in mental health, substance use treatment, tobacco control, and public health, really charged with producing an action plan to reduce smoking prevalence among individuals with mental health and substance use challenges. So even after their facilities prohibited smoking on their grounds and their campus, they still used the State Leadership Academy and the State Strategy Summit to facilitate their efforts to further reduce that smoking prevalence. I do want to quickly put in a plug because our partners at SAMHSA, Smoking Cessation Leadership Center, I think is hosting a breakout session tomorrow. So if you're interested in learning more about those state leadership academies, I encourage you to check that out.
North Carolina. So North Carolina participated in our community of practice actually last year. And they brought to the community of practice their partners at their state Medicaid office. And what they did collectively was to establish this robust action plan as part of the community of practice. Now, it's important to note at that time, North Carolina had not expanded Medicaid. And so you can see here some of the progress that they were really able to make. So at the time, without Medicaid expansion in North Carolina, there were actually their mental health organizations and their substance use treatment organizations, they have a high rate of serving Medicaid recipients, right? And so it was really important that we expanded that access through Medicaid. And so what has happened since is that Medicaid managed care plans are required now to increase the use of tobacco treatment medications and counseling. They train care managers on brief intervention and standard of care tobacco treatment, as well as providing the quit line services. I do believe that as of now, and this is, I think is recent, North Carolina did just vote to expand Medicaid. So this has huge implications for further ensuring that equitable access for individuals with mental health and substance use challenges. And lastly, Arizona. Arizona Department of Health, in partnership with the University of Arizona College of Medicine, created this Helpers Through Behavioral Health program, which uses this clinical approach to partner with behavioral health agencies and FQHCs, federally qualified health centers, FQHCs. They recruit, train champions. They offer CEs for in-services for prescribing providers, as well as provide training to their members, right? Through the community of practice, and Arizona was also a participant in our community of practice last year in 2021. They were able to adapt that model for remote delivery because we were still in the pandemic, and they had to figure out a way to adapt, right, to the current environment. They were able to onboard agency leadership, which was very key. They were able to identify and select champions at the agency sites. They developed this administrative data dashboard for monitoring progress over time, really emphasizing policy interventions and resources. And then they were able to disseminate that information from the community of practice to their community partners. So these are just some of the highlights of the work that we are able to work with states as well as providers in really addressing that disparity for individuals with mental health and substance use challenges. Thank you.
Thanks, everyone. I know we're excited about the Q&A session, so I'm going to ask Hannah to give me 5 minutes, and then we're going to transition to the Q&A session. So I didn't introduce myself. I'm Dewana Ardeep Calhoun, National Network Director for Self-Made Health Network, and our priority populations consist of populations with lower socioeconomic status characteristics. So we'll start with just providing just a general overview of who we are, and then just some of our health systems work, because I have another presentation later today regarding that work. Right. So we wanted to ensure that we aligned with at least one of the essential public health services, and that the one that we're going to feature is just enabling equitable access. And so this is just a snapshot of some of those characteristics that we were referring to. So by income, our priority populations consist of populations whose maybe their annual income is at or near the federal poverty level. And that includes minimum wage workers as well. By geography, that includes residents of medically underserved areas, as well as health professional shortage areas. Then by level of education, for populations who maybe their highest level of educational attainment is a GED. So those are some of our priority populations. Health insurance, that includes the underinsured as well as uninsured populations. And lastly, employment status, that includes our low income populations who may be self-employed or maybe full-time workers, contractual, seasonal workers as well, and self-employed workers, well, just self-employed as well. into our network. I know we focused a lot on what we've done throughout our presentation, but we want to just provide you a snapshot of who we are. So you just kind of follow that big blue box. We have what's called our Leadership Council, our National Advisory Council, and we have vast representation. I'll provide just a few examples of those organizations, just in case you're not aware that they are in your state. And they include, for instance, Northwest University's Feinberg School of Medicine, West Virginia University's Cancer Institute, as well as University of Alabama School of Nursing, Meharry Medical College, Public Health Foundation. So if your public health agency is striving to attain accreditation status, they're on our advisory council. I love it. Okay, Kansas State University in Ohio, Michigan's Community Health Workers Alliance, Louisiana Public Health Institute, and then one of our most loyal members who retired recently was from Wisconsin School of Medicine Center for Tobacco Research. And then we also are comprised of national network members. A few are in the audience, which is really nice. Some represent, for instance, Ohio's disability programs, YMCA. We saw Eric earlier, Arkansas's Nurses Association, as well as other organizations. So please visit our website. We also are structured with what are called regional resource lead organizations. So one of those organizations is the University of Kentucky's College of Public Health. And they've been one of our regional resource lead organizations for several years. And their work was actually featured at the 2019 National Conference on Tobacco or Health. It was wonderful, but it focused on lung cancer screenings as well as men's health. Our work regarding that regional resource lead organization was also featured at APHA. How many people are familiar with the American Public Health Association's annual conference in men's health and cancer, as well as the American Association for Cancer Research and the CDC's National Cancer Conference? Our partnership work was also involved that that entity as well. In reference to our grantees, later today we'll be focusing on our South Carolina Rural Health Tobacco Cessation Initiative, and that involves the adoption of the United States Public Health Services Clinical Practice Guidelines for treating tobacco use and dependence in 3 rural health clinics in South Carolina. It's just wonderful. And then also, as we continue to expand our specialized training and technical assistance services, we are happy to just announce that we also have on board the University of Emory University's Rollins School of Public Health, the Public Health Training and TA Center. Are you all here? There we go. Wonderful. So when they email you all, please say yes. And they focus on particular topics, including just community-based, for instance, community-based policy systems and environmental changes. Anna, how am I doing? All right, good. Okay, so South Carolina Rural Health Tobacco Cessation Initiative was so wonderful. Okay, so that's going to be in our session later today at 3 p.m. And then also as part of the support that we provide to state tobacco prevention control programs, as well as national comprehensive cancer programs nationwide. Listed on this slide is just one example of those efforts. And we have in the audience our Oral Health Coalition in Pennsylvania in collaboration with Pennsylvania's Tobacco Prevention and Control Program. And the focus is on refining some of their data so that they reach more counties with lower socioeconomic status characteristics by ensuring that there's an increase in the workforce among our dentists and our dental assistants to adopt the United States Public Health Services guidelines, clinical practice guidelines for treating tobacco use and dependence. And then also just a snapshot of some of our webinars. Please go to our website. You can enroll in any of the webinars at any time, and you can also access all of the downloadable resources. Good. Okay, Q&A, because I want to make sure that we answer your questions. Any questions? All righty, good. Okay, sir, here we go. Okay. You're asking for a lesson learned or a successful strategy that has been adopted? Okay, are you all? Is it related to a particular topic or particular national tobacco goals? Or? Okay. And thanks everyone for attending. I know we're between lunch too. We're about to transition to lunch.
I would say, I think the common theme you heard up here, whether we specifically noted it as a lesson learned or not, is partnerships, partnerships, partnerships. Across sectors, as diverse perspectives that you can engage and get on board and develop a common mission and action plan to achieve what it is that you're trying to achieve.
And I'm basically reiterating that same sentiment. The coalitions, multicultural coalitions. So although we've got specific populations that we're working with, the coalitions doing the work should be multicultural. To just show support that there is widespread community support. And you've got to know who's in your community, what their stance is, and if they don't necessarily have not been on board in the past, why? Because we're one community, and including every piece of that community, every multicultural segment of that community on your coalition can only lead to greater success.
I would add to that that communities know themselves the best. So always involve community input and involvement. And, you know, they are really key and instrumental in the change that you need. And you also need to have not just people of diverse backgrounds, but also diverse industries. You know, it takes a whole entire village to do something. So you need everyone on board, and don't have any real issues with reaching out to people. You will always find champions where there are champions to be had. Andrew, would you like to say?
Hey, good morning, everyone. I'm Andrew, the director of the Geographic Health Equity Alliance. Our presentation was about our policy surveillance collaborative. So our lesson, I think, is just a tiny bit different. We learned that we are all amateur policy surveillance folks, and that was sort of our big takeaway from this. Is like all of us do this, all of us work in policy systems and environmental change and are out there collecting policies, coding policies, trying to interpret policies, scoring policies. And it was kind of a aha epiphany for us to find out that there's a field of public health called legal epidemiology, and professionals who spend their time developing rigorous processes to actually interpret laws in non-biased ways. And so the big aha for us was we can piggyback off of all of this knowledge of this whole new field of public health and borrow their methods and practices. And we strongly believe at the end of all of this that this is a competency that tobacco control would be well served to learn and adopt, and eventually start training everybody who works in this field on the competencies of this subdomain of public health.
I have a quick one. I know we say view communities where they are. For us, when we began the work in Kentucky, we love data. We started with data. So we asked our Kentucky partners to focus on 8 counties that were primarily comprised of high prevalence rates related to tobacco-related cancers, tobacco use as well. And when they started to work with work sites, blue collar work sites, because that was who we wanted to engage to reach a lot of low income males too. Some of the work sites had various levels of infrastructure and capacity. And so they continued to work with the various work sites to meet them where they were so that they could become successful. And then also work with sectors based on maybe what their priorities are as well. So for some work sites, they were interested in tobacco cessation. Others were interested in lung cancer screenings. And then others were interested in policy adoption. So it doesn't have to be an all or none option for work sites. Meet work sites where they are as well. That was one lesson learned. And then we began to expand our model throughout the state. And then in the last 2 years, brought on the Kentucky Chambers of Commerce to reach even more work sites, because sometimes people think that because you are a big company, you don't have low income employees, but you do. They exist. So that's all. to ask questions? Okay, we're ready.
I think the best time to start building a coalition is as soon as the conversation starts. If there's not already a coalition, because again, once that coalition is formed and you've begun working on whatever the topic is, the hope is that that coalition remains intact to then move on to the next piece. Even if after, say it's smoke-free air, we want this apartment building to enact a smoke-free law or smoke-free policy. You're successful and that smoke-free policy is enacted. Now that coalition, they've got experience, they've got their name out there a little bit, they know how to do the work. That's not the only piece of work that needs to be done in that community. So as soon as something comes up that's going to involve a community coalition, and if anything comes up in the community, there needs to be a coalition. And that coalition should have the ultimate goal to maintain afterwards. So that's what I would say is as soon as the conversation comes up, because most of the time it's going to come up among us, the public health folks, start reaching out to the community, not just community organizations, but even individuals, faith-based organizations. Again, every sector has got to be multicultural, males, females, LGBTQ plus community. Everybody should be, I mean, we can't have everybody represented, but the idea is to start as soon as possible and to include as many folks as possible.
You have a question over here too, to the left?
Yeah. The key word is community coalition. And when we say community coalition, like you just said, involving those folks in the community, the working moms, the 9-to-5 workers. And what that's going to entail is the meeting can't be at 11 a.m. Not every meeting can be at 11 a.m. on a Wednesday, because at 11 a.m. on Wednesday, you know, Mrs. Smith she's working or she's running back and forth, picking up the kids, dropping them off to school, daycare. So there's got to be a level of understanding that this community coalition is not going to be a community coalition if when we meet, they can't come. That's not a community coalition. That's a coalition, but not necessarily a community coalition. So the flexibility to meet after hours is imperative. And somebody else said it, maybe it was said more than once, meeting the community where they are, that's what it's going to entail. And being in public health, you know, many of us do have that option to be that flexible. Oh, you all can't meet until 6:30 p.m. on Tuesday. We'll make it happen. Even if it's, you know, not everyone from the public health side can attend. If the majority of the public folks, the private folks, the moms, the pops, the store owners, whoever's on the coalition. We've got to make some time to accommodate them. And that just has that has to happen in order for the coalition to feel like they are, not even feel like they are, because they should be. They should hold ownership of the coalition itself.
The other thing I would say is approaching it from the standpoint of what is important to the communities that you're trying to target and the groups that you're wanting to work with. So like, your average mom has her own priorities versus a local business or retailer. So what's important to them? And then, approach it from that standpoint. You already have your end goal, which is, likely to reduce tobacco or whatever topic it is that you're wanting to work towards. But you need to look at what your community's priorities are and approach it from that standpoint. And then that's really how you get the involvement of the community, by really paying attention to what those needs are.
Any other questions? Please ask us. Ask. Okay, Travis.
Part of the problem, I work in Santa Alexandria. This is one of the four biggest, least educated places in the United States. We do have coalitions that largely made us when we go out to really see big ranges, it's work. That's what we want to do. And then if they go to adults, then they're just like they're Washington or wherever, not proper. Like you tell what they really ask for is more jobs and better school systems. Every man is pushing those systems back. Those don't depend on public health. They depend on public policy, allocation of resources, government. And when you have hostile government, they're not interested. Then you have chronic problems that have existed for 162 years with the last slavery census in the same parish. So this is very discouraging for people because all they see is no change.
Hi, my name is Hannah. I'm from the National Native Network. And if there's one thing that I know as a Native American woman myself, is that the Native American folks have been through 500 years of, governmental atrocities and whatnot. And I've seen it in my own home community where folks are just like, I don't want to be involved with anything. I don't think this is going to work. Like, what do you know coming into my community saying that this is what I need, X, Y, and Z. And the thing that I have found most successful is to really having people that look like them come in your community and say, hey, I know the struggles of this community. I go back to my home community and say, yeah, I know what this looks like from an education side, but I also know what this looks like from the home side. So bringing in folks that know exactly what, they're looking for. And we have seen it in all the communities of color where folks come in with their white savior hat and say, I can fix you and I can save you. And I really think we need to have that conversation of bringing our own folks into our own communities versus, somebody from the outside saying, this is what you're doing wrong. This is, you're poor because of this, you're poor because of that. So really look at bringing folks who look like them and who understand the struggle and who understand what they're talking about versus just saying, well, they've been poor and sick for 500 years, then we're just going to sort of give up on them. And those are the people that you really need to look at most versus the folks who are in the higher, wealthier communities. And so really look at taking your white savior hat off and saying, all right, let's break this down. Let's put the community first. And what do you want to see? What does a healthy community look like to you, the individual within that community?
And you mentioned a key term, resources, and folks are beaten down. So the root cause, like, why are they beaten down? Is there something to do that will improve that piece of it so that they feel less beaten down and then can see a little bit of light at the end of the tunnel to then focus on something else? But that resource key is key. And what we should be doing, as well as providing training and education, is providing resources. And the resources, monetary resources are always good. But if there's other resources that can be provided, you mentioned, schooling, even the healthcare system. How can we navigate making some improvement in that, some visible improvement in that? And I mean, I know we don't have the answers right now, but those social determinants of health are key to address, because there's going to be levels of the social determinants of health. If folks are feeling beaten down, they're feeling that the impacts of 160 years of racism and 160 years of being in this town, and their voice not being heard by the decision makers, it's tough. So I mean, your question, your point is exactly on point, and it's a discussion that needs to be had with resources, giving those folks resources, not necessarily the resources that we may be talking about for tobacco control, because they're not ready for tobacco control when their kids don't have a safe walk to school, or their kids are going to school hungry. The tobacco conversation kind of falls down the wayside. So being able to recognize what's important to the community, kind of blending your tobacco work into that, even if the tobacco work takes a background for a while, but you're not going to make any movement until those things that are bubbling to the top for them, until something happens there and they can see some effort there. So, I mean, it's an awesome question. We could probably have a whole session on that. But yeah, I definitely, and we work with folks in Alabama that have expressed that exact same thing. So yeah, it's a good question. Not easily answered.
I would say, just to add to what everyone has said on the panel too, in addition to kind of to identifying or really asking what the community's priorities are, and sometimes it's helpful to also work with communities to help them identify what their assets are. What are some things that's valuable to the community? And then in some instances you can tie it to health, but then also in reference to the decision makers. That's a wonderful one, because we always hear disparities, health equity, that's a part of our world, but to just decision makers who are not a part of that world, sometimes you have to account for incremental learning and walking them through acquiring a better understanding of what health equity is and what it means to their communities, what it means to businesses as well. And then also just helping to identify, when they say jobs, what jobs and what sectors, because that may be an opportunity to work with certain industries to bring in additional resources to identify jobs that may align with the education level of those communities as well. And I'm not sure, I'm not sure if they're community health workers actively involved in those parishes as well, because that may be another option to identify opportunities to create some form of income for community health workers, or to identify organizations who can help to develop proposals so that more resources can be brought into those parishes, including maybe some parishes that are food deserts, because then if you bring in a grocery store, that's jobs. So that's one way to get the community involved and valued, and then helping to support the health, the health outcomes for the entire family. That helps a little. But we're more than happy to work with you all, because that's a wonderful one. Yeah. Any other questions before we conclude? No, you're so quiet. All righty. So take a picture of the beautiful banners. We're so proud of our banners. Take them so you'll know about us, and then go to our websites as well. Thank you.